talk about anesthesia, what it means is you may have a controlled loss of consciousness. Usually there should be some analgesia, and then areflexia. The patient shouldn't normally respond. And most of the cases you are going to do, you need some level of muscle relaxation. So, the important basic tenets of general anesthesia. Now, I'm going to ask you a few questions. What is analgesia anyway? Relief of pain. Okay, so what is sedation? Pardon? A reduction of consciousness. Okay, you have an idea. What is hypnosis? I'm not talking about a clinical psychologist. Sleeping. Okay, that is excellent. That is very good. And then when we talk about amnesia, there are two types of anesthesia. Amnesia, what are they? Anterograde and retrograde. So if you give somebody pre-medication, what type of amnesia do you get? Anterograde, for events that happen after you've taken your drug. So you don't sign a check after you've taken midazolam. You remember who you gave the check to.
Good information.
Then relaxation means, or let me go through. Analgesia means just blocking the conscious sedation of pain. The pain will be there, but then it doesn't get to your thalamus. So right from the periphery till you use morphine, which works at the level of the brainstem, you can actually change the consciousness of pain. So it doesn't mean the pain is not there, but sometimes you actually block the pathway. And then sedation, there are two definitions of sedation. Sedation means you sleep, but then your eyelash reflex is preserved. So when I touch your eyelash reflex, you should wake up. Are you with me? Sedation means you are asleep, but I can easily let you get up. And then you should be able to talk to me in a purposeful manner. Do you understand? And that is what sedation is. And then when we say hypnosis, like you said, it's unconsciousness without analgesia, which means the patient is actually what? Completely knocked off. And be careful, the hypnosis I'm talking about is not like the clinical psychologists do, where they make you, I think it's a very dangerous thing. Because you see, they empty you, and then they are very suggestive. I don't know the the spiritual implications of hypnosis, so I don't think it's something I want to go through. And then amnesia means memory formation is prevented or interrupted. Do you understand that? So that if you're going to think about regional or anesthetic techniques in your office or your practice, I think it's always good to have a level of amnesia, just in case they come back the next time. Okay, my wife had an endoscopy with midazolam. She can't remember the whole procedure because I think it's very uncomfortable. But the vast majority of us do a lot of these procedures without any sedation at all. You understand me? It's always good to do it so that if you get repetitive endoscopies and things, come back. And relaxation just means unwanted movements or reduction in muscle tone. Then, like I said, the other definition of or a sedative is a drug that causes what? Drowsiness, calmness, and then there are mental changes that are conducive to sleep. So that if you sedative, it's likely that with the reduction in anxiety and the calmness, they will actually go to sleep. And the definition I gave you about, the definition I gave you about sedation, sleep with the preservation of the eyelash reflex, and purposeful response to verbal or physical stimulation. Sedation is when there's a reduction in anxiety, stress, irritability, and excitement by the administration of drugs. But then there are different types of sedation. You remember Michael Jackson died? And Michael Jackson, he was given sedation. But then I think the person who was given the sedation made some capital mistakes. And when I finish, you understand why he died. If you talk about minimal sedation or anxiolysis, it means that it's a drug-induced state during which the patients can respond to you verbally. You understand me? They may not be able to remember most of the things you're talking about. Concentration and coordination is impaired, but they can have a conversation with you. Okay. And then you have moderate sedation on analgesia, which means the first one was a depressed state. Now this one says depressed what? Of consciousness, which means a much deeper condition. But the patient may still what? Respond purposefully to commands, either alone or with light tactile stimulation. And patients in this state can breathe on their own. The dangerous one is, you should never do it, combination of drugs in outside a hospital setting. When you combine a sedative drug with an analgesic drug, the chances are you will lose your airway. Okay, so if you look at this, drug-induced depression of consciousness, where patients can respond easily, except with deep stimulation or pain, and they may be unable to maintain their airway. Michael Jackson, I'll talk about some of the venous anesthesia so you understand. The guy used a combination of propofol, another sedative, and a benzodiazepine together in Michael Jackson's bedroom. And the combination may have depressed his respiration, which he didn't pick up. And then he went into cardiac arrest. So by the time they got him, he was actually dead. So there are some drugs you should never give outside a hospital, or don't combine in your hospital practice. Otherwise, you have the side effects, which is mainly respiratory depression, and that is what actually killed Michael Jackson. Now, general anesthesia is a depressed, drug-induced depression of consciousness during which your patients are not aroused at all, even by painful stimulation. Okay, so in general anesthesia, it means your patient is asleep. If I make an incision, they will not even be able to respond. And in that condition, your patients normally, most of them may not be able to maintain their airway. So we normally either intubate them or put in a laryngeal mask to aid their respiration. Okay, so that is the one general. I think you have to be careful. The transition from deep sedation to general anesthesia is blurred. So as soon as you get into deep sedation, it's likely that you are getting near to general anesthesia. And you can induce anesthesia using inhalational agents. I'm sure you learned that in medical school. Or intravenous anesthetic agents. Okay? And anesthetic agents, somebody will give you the lecture on the inhalational anesthetics. Then, of course, you've learned about regional anesthesia. Regional anesthesia is when you cause varying degrees of muscle relaxation by administration of local anesthetic drugs. What you can actually do is inject a local anesthetic around a nerve or a bundle of nerves to block impulses to a certain part of the body. And when that happens, there is full analgesia and then some level of muscle relaxation. And somebody will do anesthesia as a whole. It's one thing that you can actually use in your practice. Then if you talk about, it means you deposit a small volume of a local anesthetic in the subarachnoid space. Okay? And if that happens, it means you block most of the sensation from about T5, which is just around the subcostal area, right down. So there's lots of sensation there's no pain, and there's muscle relaxation. And that's what we use for about 94 to 95% of our cesarean sessions in the hospitals now. And in most of the districts, that's what is actually being used. Somebody will discuss that in a little bit of detail later for you. So if you look at it, your spinal needle goes through skin, subcutaneous tissue, the dura mater, the subarachnoid space, and then the volume, the drug is actually injected into. Now, our main topic to give you a few definitions so that you actually understand. But our main topic today is intravenous anesthetic agents that you, when given in adequate quantities, will induce anesthesia safely and reversibly. If it's not reversible, then the patient, okay, it has to be what? Reversible. And what it means is that you should give it in sufficient quantities, and it can be given either intermittently or by drug infusion. And as I said, a drug or what? Combination of drugs. One other old definition was a drug that causes loss of consciousness in one arm brain circulation time. So if I put a needle, cannula in your arm, I inject the drug, it goes along the arm to the right atrium. It goes into the lungs, to the left atrium, left ventricle, goes into the brain, and you are asleep. Okay, that was the whole definition. But ketamine doesn't do that. If you give somebody ketamine, they don't sleep in one arm brain circulation time. It takes a much longer time. That is why this definition is much better. Anesthesia safely and reversibly, and it should be given in sufficient quantities. And as I said, it can be given by infusion or intermittently. Now, I want you to understand, all intravenous anesthetic agents are either, they come in either aqueous solution or as oil in emulsion. And they should be unionized at body pH for them to cross the blood-brain barrier. If your drug is soluble, then it doesn't cross the blood-brain barrier. Atropine is very highly charged. It doesn't cross the blood-brain barrier. Okay, all our anesthetic agents are oil or let's say lipid soluble, so they cross the blood-brain barrier relatively easily. Now let's look at the examples. I'm supposed to set some MCQs for you. I haven't said it. I said they use it to assess whether what I'm saying you understood or not. Okay, so I will set them. And normally you set your own MCQs by the questions you ask. And we realize the problems you have here in your head, and we use that to set your so, they are divided into rapidly acting. The barbiturates, the commonest one is tapentone. I've added methotrexate in red. I used that when I was a resident, and I'll tell you what I use that for. Phenobarb is still being used for some levels of epileptic or convulsive disorders. And you should know that it's a barbiturate. Then we have what we call imidazoles. I think for completion's sake, I'll talk about them. Then phenols, which is propofol, which I'll talk about because I think you should avoid it. If you're going to give propofol outside the hospital, you should have either an PA or a doctor because of relative side effects. Then we have the slower acting, the benzodiazepines, the dazolam. The last time I've used that in the last 15 years. I don't touch it at all. And I'll tell you why. And then large opiates. And then these are some drugs that we use quite a bit, especially in our intensive care areas or recovery ward areas. The reason why we use them. Right, now these are the characteristics of the ideal intravenous anesthetic agents. I will leave a lecture for your people so you can actually look through. The main thing is They should be cardiovascularly stable. They shouldn't depress your respiration. There should be no pain at the site of injection. It shouldn't cause nausea and vomiting, especially if you're going to send your patient home afterwards. So they are a few of the things that I think you should know, but they are very good for multiple choice. Then we have something we call TIV, which is total intravenous use in a lot of the districts where the anesthesia is only provided by intravenous anesthetic agents. There's no inhalational agent at all, not even nitrous oxide. So if you're going to ventilate the patient, it's oxygen and air. And then you use the intravenous agent to keep the patient completely asleep. The commonest for us as anesthetists is propofol. Do you understand? And the commonest for other people who are outside the main hospitals is what? Ketamine. It's brilliant. And I'll tell you why it is safe under those circumstances outside a general hospital. The advantages of inhalational agents, as the patient breathes out, you also breathe in. So by the time you realize the surgeon is sleeping, the anesthetist is sleeping, because the inhalational agent hangs around the table, and that makes it very difficult. There is less cardiac less oxygen consumption, and there's less post-operative nausea and vomiting. And in daycare anesthesia, for you, especially if you can't control your airway, it may be your drug of choice. And before I forget, if you ever decide that you're going to be given some of these drugs in your clinic or your practice, then you should learn CPR. Not being able to intubate, because the patients may get an anaphylactic reaction, or react to a drug, or get hypotension, and then you should be able to resuscitate them. Otherwise, they die. I think 4 months ago, in our eye clinic, now the eye clinic in Kolebu is almost near the mortuary. That's frightening. And they were doing a local procedure, which is just medium. They gave it, reacted. They couldn't do CPR. By the time we ran from the main hospital, it's funny, the road, she was dead. Just an investigative procedure. So that you have to be extremely careful about these. So take your CPR. If I had my own way, we'll come and examine every one of you for the CPR before you finish your modular course. I'll tell your coordinator that we should do that, so that at least the basics, the 2 hours they are giving you is hopefully inadequate. It's going to be too theoretical. I think they should find an afternoon, bring the dummies, and allow you to practice before you finish. Then Taupenton, when I was talking about the barbiturates, don't worry, I won't bring this in your exam. This is the structure of the barbiturate ring. And when you substitute these with alkyl or aryl groups, then you get the different types of barbiturates. Now, if you put a phenolic compound here, then it becomes phenobarbitone. Phenobarbitone just has compound here. Okay? If you just use alkyl groups, you get taupenton. Okay, fine. So taupenton is common. In the Western world, they stopped using it. They are using propofol. There are people who can't give an inhalation anesthetic. They forgot it. What they're just doing is just propofol I use propofol for all my open heart cases. It's supposed to be contraindicated, but it depends on how you use it. Okay. But in the Western world, taupenton is gone. We are now having difficulty buying them. We are going to India and a few places. The problem is that the drugs that come from there don't have the same potency as the ones we are buying from Europe. You may have to use slightly more. We have some Bangladesh muscle relaxant. When you give it, the patients, they're supposed to be paralyzed. they still move around. So those are some of the problems. That was the only thing on the market that we could buy. So you may have those issues. And normally it is a yellowish pale compound. Some of the things are right here. When we're medical students, they use them as multiple choice. Terrible. Tapentone is a sulfur analog of pentobarbital. If you remember, it comes a lot in multiple choice. But don't worry, I think I'll set more practical questions for you. One good thing about it is that it is very bacteriostatic because it's very alkaline. So you don't inject terpentone into the tissues. Otherwise, the skin will just slough off because of the high alkalinity. This is just a few of the kinetics. I think you should understand kinetics a bit. Kinetics mean due to the body. Sorry, dynamics is what the drug does to the body. Kinetics just deals with the way the body handles it. And I think you should understand that terpentone has, when you give it, this is your dose that you give into the blood. It drops. But you see, it goes to the brain and the very rich groups, then muscle. And then it goes and stays in the fat. So after 2 weeks, you can still get the products of terpentone in your urine. So it stays in the body for a very, very long time. And then what I don't like about it is that it says it has zero other kinetics in the metabolism, which means if I give 1 gram and the patient sleeps, it will just metabolize 10 milligrams per hour. It won't change. So the 900 milligrams will be there. They will be going slowly. Every hour, 10 milligrams, 10 milligrams, 10 milligrams. So if you give a very high dose, which they use sometimes, your patient can sleep for 2 weeks. Yes. And we use that sometimes. And I'll tell you what we use it for. That's terpentone. So that you should understand your drugs a little bit. Now, it's a sedative. Depending on the dose. It's a hypnotic, if you use it as a general anesthetic. They are brilliant anti-convulsants. Okay? But don't forget, what is this? Anti-what? Analgesia. So terpentone, when you give it, to put you to sleep, but you have more pain. Because it doesn't actually help. You have to give something else for the pain. The others, you don't, but that one you need it. And it doesn't affect people with brain problems. For us, it's important. A head injured patient or somebody with epilepsy or otherwise, when you are giving it, you can advise people that terpentone is relatively safe. It causes extensive hypotension, especially if your patient is hypovolemic, hypertensive on beta blockers, and it reduces your blood pressure significantly. It may cause some respiratory depression and is notorious for bronchospasm and laryngeal spasm. So for an asthmatic, I avoid terpentone almost completely. So I think those are some of the points that you should take. I think the thing is you should understand some of the doses. Pharmacology, the doses when they examine you can get 9 out of 10, or 10 out of 10, or you can get 0. That is if you don't, the doses. For us, we have to. I don't know, I'll decide. The dose is 4 to 6 milligrams per kilo. You can give it rectally. You understand? At 22 milligrams per kilo. Now I mentioned that you can give terpentone to people with very severe head injury. Somebody has severe head injury, he's deeply unconscious, and we can't get it to bring him back. We can give them huge doses. Have you seen that? 10 milligrams per kilo. The dose is what? 4 to 6. After that, you infuse 5 milligrams per kilo for what? 3 hours, and then 1 to 2 milligrams for some time. If you think that the brain injury is reversible, we give them what is called a barbiturates coma, and we ventilate them. I told you, this terpentone is given is going to go where? Into the fat, and it will be metabolized at what? A very constant rate. So when you do that, it means be ready to ventilate your patient for about 2 weeks. Okay, and it is brilliant. It saves quite a lot of people when we do that. We've done that in our ICU a couple of times. But you should, in your mind, you should realize that the outcome has to be what? Good, otherwise a futile exercise.
It has its own lot of problems.
rape, and it may cause certain side effects, which I'll show you in a minute. So sedation, induction is brilliant for status epilepticus. But like I say, you don't give gabapentin and other things in a site outside a hospital, unless you can do something about the patient's airway. Severe head injury, as I said, we use it for barbiturate coma. There are contraindications. If the patient has porphyria, if the patient is a heavy drinker of alcohol, gabapentin will aggravate it, and you may get problems. You may get anaphylaxis. And then we have other complications, which I'll just leave on your slide for you to know. If you inject it, I told you, outside the tissues, you get sloughing of your tissues. If you inject it into an artery, which if you are doing anticubital injection, if you inject it into the artery, it goes into the artery, causes the artery to vasoconstrict, you may lose the whole hand. You understand? So I think you should be a little bit careful about that. That is why some people are going off tapoting for the other drugs. I said I'll mention this briefly. I used it when I was a resident. And although it's a barbiturate, it is not anticonvulsant. It is pro-convulsant. So what do you think they'll use it for? ECT. So it is excellent for ECT, because when have you seen ECT before? The depressed people in the psychiatric hospitals, they put these things, they pass electrical energy through their brain, and then they have strong faith. I didn't believe it, that it will work. But I did a list when I was a resident for 6 months. It looks barbaric, but then after 3-4 weeks, the few suicidal people, when I see them, they are almost completely cured. So I became a convert. Unfortunately, in our psychiatric hospital, they give the distance without sedation. It's wrong. That is the barbaric aspects, and that shouldn't be done. So that is the main use of methotrexate now. And of course, I've talked about phenobarb, which you can. It's relatively safe if you be careful if you're giving an IV. But if you're giving IM, it may be helpful for some of your patients who are getting tractable status epilepticus. Then ketamine, which I think you should know inside out, because it is one of the drugs that are very slow onset. It causes what we call dissociative anesthesia. It has intense analgesia and superficial sleep. So your airway is nicely preserved. So you are not likely to lose your airway with ketamine. So that is one excellent thing about it. These are the doses. Not all of them are for you. The dose that you can use to put somebody to sleep is 1 to 2 milligrams per kilo. Don't be putting people to sleep in your clinics. For analgesia, you can use, you see this dose. If you give it to somebody who is in pain, it should be enough to let the pain go. But they will maintain their airways very easily. That may be helpful for you. Okay? Do you understand that? And then the combination with propofol and this, you can use it sometimes for surgery. You shouldn't do that. It can be given orally at doses of about 10 milligrams per kilo. It takes about 60 to 90 minutes to work. But don't forget about the side effects of ketamine. You are aware. It causes a sympathetic reaction, and your patients may have a hypertensive crisis on you. Tachycardia, increase in cardiac output, and vasoconstriction, and your BP goes up. Also, your patients who are hypertensive or has significant renal or CNS problems, have a stroke before. If it's an epileptic, you don't use ketamine. Now, until recently, it said that anybody who has a problem with his brain, we should use ketamine. Now they reversed it. They are saying now we can use it for people with problems with their brain. But don't use it for epileptics. They will get an epileptic attack. Ketamine has these side effects. They may get hallucinations, vivid dreams, And you can reduce that by giving them a benzodiazepine. Which one will you choose? Midazolam, short, very short acting. I've come to midazolam very briefly, so that is very good. And as I said, they use this TIVA induction, difficult airway, Ben's dressing. See, if you're in radiotherapy or otherwise, and you are far away from the hospital, they help. Field situations. If you can give it on a field, you can give it in your clinic. Okay, you have to be very careful. Complications, hypertension, epilepsy, increase in intracranial. If you give ketamine to somebody with a penetration eye injury, the vitreous will be extruded and the patient will go blind because it causes a lot of nystagmus. So you don't use it in people with eye injuries. Propofol, the Michael Jackson drug. And I'm teaching you so that you run away from it. Okay. It looks like milk, whitish. And the chemical compound is diisopropyl. The formulation is funny, isn't it? Soybean oil, X-phosphatide, glycerol. So you don't open an ampoule of propofol and keep it. Bacteria will colonize it in the shortest possible. So when you open it, you use all of it. And it is only given by intravenous route. Ketamine can be given IM, orally, IV. The doses are there, so we'll give that to you. And it is metabolized very rapidly in the liver. Just a little bit is left unchanged. Now, if you look at the doses, even us as anesthetists, we are always scared. Fit adults, that's the dose. If the person is more than 60 years, you see the dose very small. Children need a much higher dose. But just remember, like I told you, it's one of the drugs that we use for total intravenous anesthesia. When I'm doing open heart and go on bypass, we stop ventilating. We stop ventilating the patient, so I can't use an inhalation agent. The only way to keep the patient asleep is running an infusion of propofol through a vein, and that's what keeps them asleep while the surgeon is working on the heart that they have stopped. Okay, that is TIVA. Okay, total intravenous anesthesia. And as I said, you have to give the drug very slowly. That's for the fit person. For the elderly, you can see it's even given more slowly. Otherwise, your BP will fall and you'll be doing CPR. Okay. Now note that all intravenous anesthetic agents have what? They cause sedation, they cause hypnosis, they reduce your cerebral blood flow, intracranial pressure, reduce your intraocular pressure, and reduce your cerebral use of oxygen, except ketamine. Ketamine, apart from it being a sedative and a hypnotic, will have the opposite of all these. That's why you should be very careful about your patients. If you decide to use any of those drugs in your clinic, then you have to get a very good history before you go ahead. Don't use ketamine for manipulation of bones. Why? They become stiff. So your manipulation will be useless. They get severe hypotonus. So there's no way you can bring that bone back or pull a dislocated shoulder back into the joint because of the effects of that ketamine. Right. Then etomidates, for completion's sake, is one of the drugs that I use a lot when I have a very poor risk patient everywhere, because it has no effect on the respiratory system. It has no effect on the cardiovascular system, but it depresses your adrenal cortex badly. Everyone knows. So now the majority of people are not using it. So we only use it under very severe problems. The other bad thing about it is that it's notorious for nausea and vomiting. I'm getting to the end. Benzodiazepines are drugs that produce sedation and hypnosis by depressing the limbic system. Normally, the benzodiazepine receptor is connected to a GABA site and a chloride pore site. And what it does is that it increases the negativity of cell membranes. so that they become so negative that even when you want to stimulate them, it becomes difficult. And that is the way it works. Most of them are categorized as short-acting, intermediate-acting, and long-acting. Which ones are short? Midazolam. Yes. And then which ones are intermediate-acting? Lorazepam, oxazepam, and long-acting. Why is diazepam long-acting? I agree with you. He says they have a longer half-life. But why?
Lipophilic.
Absolutely. So one bad thing about diazepam is some of the end products are actually other benzodiazepines. One of the products is oxazepam, which is sold on its own as a benzodiazepine. Secondly, it has what we call the enterohepatic circulation. You know, it's funny. You take diazepam, you sleep, you wake up as if you're okay. Then you start sleeping again. The drug has gone into the gut, it's been metabolized, then it's been reabsorbed, and then it starts what? Acting again. So, the other problem with that, it causes a lot of pain on injection, and then the last thing is that it may cause severe thrombophlebitis. So those are some of the reasons why we've gone off it. Most of what it can do, midazolam can do. You understand? With less complications. The half-life of diazepam is about 11 hours. 21 hours. 21 hours. The half-life of midazolam is about 3 to 4 hours. Okay, so if you look at it, your safety, if you look at it in terms of safety, the midazolam is a much better drug to use. And yes, I was going to ask you the CNS effects of benzodiazepines. Now I've talked about a few things, so I expect you to use the terms. What are the CNS effects of sedation, hypnosis, anterograde amnesia, and very little CNS effects? What again? They are anxiolytics, they are anticonvulsants. And then for certain spastic conditions, they may even cause a little bit of muscle relaxation. You've learned a lot. So you've done well, actually. So they are sedatives, hypnotics, anticonvulsants. They may have slight muscle relaxant properties, and they may reduce some of the things in the brain that I talked about. Now, for some of our patients who are so bad in hospital, sometimes the only drug we put them to sleep is what? Midazolam. You are so scared of the person. The person has comorbidities. I've had somebody who was 89, critical aortic stenosis, and she had gone into respiratory failure. I was so scared of the patient that the only drug I used to put the tube down was midazolam 3 milligrams and saxamethasone. For the ordinary person, that won't keep the person at all. You will have a lot of difficulty. The person will remember the whole thing, but she did it, and it worked well for her. So you can use as an induction agent. That's why I've added it to the drugs, because in the very high-risk patient, you may actually use it to treat your patients. So uses, don't forget that pre-medication, anxiolytic, co-induction of anesthesia with propofol. It has, as I said, muscle relaxant properties. And then in the hospital now, most of our neurophysicians are using it as anticonvulsants. If they are having to use something stronger, they use clonazepam in addition to midazolam, because of the safety profile. The drop in blood pressure and respiratory depression is little. So that if you are going to use 2 drugs from here, choosing, I have to go through, so you see the ones to avoid. If you want to use any of these drugs, then it's ketamine and what? And midazolam. Okay. Now for the amnestic properties, if I'm going to do a hernia on you, or removing a bump, and I give you midazolam 1 milligram, it will sedate you, but you will forget. You won't remember. The amnestic effects are with very what? Very, very small doses. You understand? So if you have a cooperative patient, just 1.5 milligrams, and you'll be amazed that afterwards, you talk, and the person will answer nicely. And afterwards, wait, a couple of hours later, what did we talk about? It's all gone. Completely. And I have patients who have passed through our ICU. They've had open surgery done. They get midazolam pre-medication. They get midazolam sedation while they're on the ventilator, and then midazolam to sleep. They go to the ward. They ask the nurses, "Me operation or they're asking whether the operation won't be done. Then they tell them, put your hand on your chest. It was done 3 days ago. That's how brilliant it is as an analytic. And I think that you shouldn't do bad things to your patients without a little bit of sedation. It is when you use combination of the drugs that it becomes dangerous. So learn that. Have you had an endoscopy? Who has had an endoscopy before? How is it? It's terrible. But that is the problem. And in Kolebu, there are some of the endoscopists who don't use it. And there are some who use it. And don't forget, the endoscopy is likely to be repeated. So I'm sure the next time you are going, you'll be, yes. But as I said, my wife, she can't remember. Up to today. She can't remember the whole procedure. They give you the midazolam while they are preparing the scope. So by the time they are inserting the scope, you've got the amnesia already. And she had the whole procedure. So next time they want to do a repeat, she'll go. You will run away. She will go because of what actually happened. Then, as I said, I won't talk too much about it again. Just notice the doses, the doses. Be careful. It's up here, 0.07, 0.1. And it's always good to orally IV. Yes. Careful. The maximum oral dose is 15 milligrams. 15 by 0.1 to 1 milligram. Okay, but don't use more than 15 milligrams. Right. Then the last thing I'm going to talk about are the neuroleptic agents. People don't understand. They don't. They are brilliant. The examples are haloperidol and droperidol. We don't see a lot of droperidol in Ghana, but I have used it a lot. And haloperidol is something we use a lot. They cause profound sedation without loss of consciousness. And sometimes the patients behave as if they are zombies. Raise your head, raise your arm, leave it there, they will leave it there, don't break it down. It's what we call the neuro-vegetative state or the zombie state. And they are excellent. We use it a lot for drug withdrawal. Patients who come to you and they haven't had the alcohol for a long time, and they may get withdrawal and they sometimes help. Paradoxically, you may get somebody who you give midazolam to, and when they are withdrawing, they behave as if like people who have taken cocaine. And the drug that you may have to use is what? Haloperidol. So we use them quite a bit. The main reason they are brilliant antiemetics, we combine them with analgesia sometimes. They're antipsychotics. Be careful. They are alpha blockers. So they are likely to drop your blood pressure. So when you're going to use it, you have to be a little bit careful. Because they vasodilate, people use it to treat heat stroke. I'm not saying you should treat your hyperparetic children with haloperidol. But then in heat stroke, very high temperatures, if you give it to them, they vasodilate. And then in that, your heat actually goes away. And for us, drug withdrawal, agitation, they are likely to maintain their airway. Just start with very small doses, 2.5 milligrams, you wait a bit, 2.5 milligrams. You understand? Don't give the 10 milligrams that people tell you to. Morphine, IV. Never give the 10 milligram they say for myocardial infarction. You kill them. They get hypertension and that's it. They die. So normally we dilute 1 milligram per ml. 1 milligram you wait. 1 milligram you wait. 1 milligram, and then you watch. Because that thing should be removed from the books. Yeah, from the books. It kills the patient. Yes. 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 So it kills most of them. So those are some of the things that, see, they're not in the books. With practice, you get to know them. So know the neuroletics a little bit. They will help you. Keep a few ampoules wherever you are. Because you may get the patient who wants to beat everybody up in the hospital or the clinic, and you may need that. I had a patient who drinks 1 bottle of whiskey during the day and 1 bottle of gin at night.
That's right.
Yes, bottle, not a glass, bottle. 1 bottle of whiskey during the day, 1 bottle of gin at night. He keeps the bottle by his bed.
That's right.
And then he had an MI. He was put on a ventilator until we sorted the problems out. Then we couldn't take him off. He was getting blood pressure, and then we were told the haloperidol didn't work. So we passed an NG tube and gave him his drug, yeah, whiskey and gin.
That's right.
And as soon as you bring it near his mouth, and he left the ICU, and it wasn't a role to take him off. That would be for the clinical psychologist or the psychiatrist. Thank you very much. Do you have any questions? Yes, yes. Yes.
I was trying to see if you mentioned epidural analgesia.
Yes, I didn't mention epidural analgesia. It is out of your range. We decided that we won't even teach you epidural anesthesia. You shouldn't be doing it on your own. You should. They'll mention it a bit. Even the PAs, they are not allowed to do epidural. The side effects are a lot more dangerous. If you go in, you make a mistake, you enter the subarachnoid space with that big needle, your brain comes down in the head and you get very severe headaches, which can only be treated properly in a conventional hospital. So we'll mention it. I took it out. I had it and I took it out. Absolutely not. It's dangerous. The PAs, the Medical and Dental Council saw us 4 months ago. And the reason being, people are dying a lot in the district. They are using spinals for everything, including ectopics. If you give a spinal to an ectopic, who is already hypovolemic, a lot of them are dying. So be very careful. They will start suing you. And look, the thing is, the last time they told us there was a patient with a leaking ectopic. Just last Friday, they presented it. Our weekend case are presented on Monday. When they opened 1.5 liters of blood. You understand? So until if you can have an ultrasound and you know it's contained, then fine. Other than that, I think you should just give a DA. In our hospital, you give a general anesthetic for every APH, every PPH, every ectopic, everybody with who has a problem with hypotension. They get a general anesthetic. If then it's a consultant who knows what he's doing. They can give an epidural for some bad cases. One of my consultants is an expert in cesarean sections with women with cardiomyopathy. If you put a spinal in a cardiomyopathy mortuary, straight, they're going to the mortuary. So he does epidurals for them. But he will put in the epidural, put in the catheter, he will sit down and be giving his drug 1 ml at a time. So that he doesn't want vasodilate them. He sits with them until the thing just comes a little bit. Then he lets the surgeon infiltrate. Then the baby comes out. The problem is, it is when the uterus what? Contracts and pumps the rest of the blood into the circulation, they all go into pulmonary edema because of the property. So, yeah, a little bit careful. Don't encourage epidural drug. If you decide to do that, get a doctor. And if you want a doctor, it should be somebody with membership or above. Or above. For safety. If you come to ask me for an anesthetist, I will never give you somebody who hasn't done membership. Because you see, you are working at a distant site and you are alone. You should be able to take some sensible decisions. Okay, right. Diploma people, we don't encourage even epidurals. Bro, very experienced, 10 years and above. Epidural analgesia, the technique is the same as epidural anesthesia. It is volume. I can give somebody epidural analgesia, slow infusion. If you want to do a cesarean session, I have to top up with about 10 mils of the drug to block most of the things and prevent a problem when you are pulling the peritoneum. You understand? And that is when you separate the boys from the men.
But when they come for the training, as in the PAs, do you teach them how to do this? Because they are with us, and
we
like
don't. Yeah.
My colleagues said they want to attempt doing
everything.
Yeah. So
no, the problem is the problem. We had a problem with the ministry. Somebody went and passed something to Parliament, which gave them some independence. So we withdrew. Oh yes, because they said they were independent anesthetists, they could work alone. So we withdrew. And one of them had a husband who was a parliamentarian and passed it through, hidden until the thing came out. Now the people are dying. The Medical and Dental Council have come to us, telling us that we should regulate it. Formerly, you couldn't, the nurse anesthetist in a district hospital doesn't work. It works under the superintendent or the district director of medical services. If he's going to do something and he tells him no, they stop. Now they tell them we are independent. And the legislator that has gone through Parliament. And now they are telling us to regulate them. We say we can't do that. You have to change the law. And they are in the process of trying to do that. So you should be able to control your nurse anesthetists. Two, you are doctors. You can pick up a few things that they don't pick up. You understand? So they should ideally work to your strengths. It's your facility. If they don't want to, get rid of them. Get other people who work within the company. They have limitations. To train a doctor to the membership level is about 3 years on paper. But you have to do a few things before, so about 4 or 5 years. To train a nurse anesthetist is about 18 months. And that's the difference. And the doctors are doctors. Their level of physiology is a lot more than the nurse anesthetist. So I have two in my cardiothoracic center. I work with them. But they don't do cases without me standing by. So, and then the cases we discuss. So you say, okay, go ahead. What would you want to do? So it's easy. Do you understand? They are being used in the US in large numbers, but they don't work what? Independently. So that is the danger. They don't do a proper pre-op assessment. They don't pick up an aortic stenosis in a pregnant woman. They put the spinal in, CPR is useless. They use stenosis. So the chest compressions, no blood will actually pass through the aorta. So there are a lot of different issues. Now you've learned about the intravenous anesthetic agents. They are the ones you tell them, hey, Jack, be careful. Be careful. Tapentol is excellent for obstetrics. Ketamine is excellent for the obstetric patients at risk. Do you understand me? Propofol, be careful. If you are hypertensive and I give you propofol, you can die. Because your blood pressure will what? Drop like a stone. So it will Michael Jackson you. Okay, so yes. Any other question? Yes.
No problem. Please, why is the dose for propofol in children higher than those in adults?
Yeah, it's funny. I think when they did the clinical studies, they realized that in the very elderly, the propofol causes more hypertension. And then in children, they found out that they were more resistant to the propofol. And we don't use propofol for any child who is less than 2 years either. They can't handle the lipid load. Propofol is formulated intralipid, so they can't handle the lipid load. So the drug studies found out that to actually get the same level of effect, they needed slightly higher doses in the. They will tell you don't use it in pregnant women. It's not that they haven't done the studies. Nobody wants to do a study in a pregnant woman and be sued. But occasionally for us, if we don't have tapento, we use propofol, but under strict what? Guidance. Right. Any other question? And yeah, that's what I'm saying. You see, there's no proper regulation. That's why you are here. That's why you are learning. I think it's about if you are in charge of your facility, then you decide the drugs you want to buy and put in your facility and tell them this is what you want to use. Or if you want some advice, if you are setting up, it's always good sometimes to talk to somebody. Somebody tell me, okay, I'm setting up for this. Can you have a look? I'm not going to work there, but I can come and have a look at your equipment for you and I can advise you what to stock and what not to stock. Okay? Next, when it's time, let me know.
Do we have the same problem with Modular? The dosage in children higher than?
No, the dosage in children is the same as adults. But it's interesting. Sometimes midazolam is a sedative, isn't it? It's supposed to calm you, reduce excitement and irritability. Amazingly, sometimes in children, they become aggressive. For some of the children, when you give it to them, they don't like losing control. So when they are going off, they may even jump off the table if you don't restrain them. So you have to be careful. It will pass through that stage before they become. But don't use a much higher dose. Otherwise, you get what? Afterwards, respiratory depression. The respiratory depression is dose dependent. Use only the specified dose and wait. Midazolam, the maximum effect comes after 90 seconds. Don't be repeating it. So you give it and then you wait. It doesn't cause sleep in one arm what? Brain circulation time, like I said. That one and ketamine do not. Propofol, tapentone, they do. So you should just be a little bit patient. Right.
Yeah, bro.
Yeah.
The issue of regulation, the nurse and the PAs. Nah, but do you work together with them? If you work with them, who is their boss?
I'm the boss.
But you don't regulate them.
I regulate them. If, in Kolebu Teaching Hospital or the big hospitals, when there's a doctor, the doctor is the boss. You understand? And you actually look at the case, you do your proof assessment, you assign patients to them. But see, about 90% of the districts do not have, not only that, even I think Cape Coast has one. I'm talking about the regions. Efia Kwanta has one. Ho now has one. Koforidua has none. Tamale had one. And I don't know whether he's still there. If he's left, then there's none. There's nobody in Upper West. There's nobody. Now the OT and the others, I'm even more scared. Because they are not even set up. So even the regional hospitals do not have doctor anesthetists. So it's nurses. And therefore, the regulation should have been better. Previously, they were under the district director of medical services, or the person who is in charge of the hospital. And because you've done a little bit more, you can determine that this patient is at high risk. So let's be careful. And one thing, they've been putting the spinal, most of them are forgetting how to intubate. Be extremely careful. About 70-80% of them cannot now intubate. So they are using the spinals for everything. And they become a huge risk. So be careful, extremely careful how you run your facilities. Lister. When you go to Lister and you want an appendix, you may pay 40,000, 50,000. for that, but they were using us as anesthetists. And so I think recently a 9-year-old died. He had eaten. This is in, I shouldn't maybe have mentioned the clinic's name. It is not the clinic, but then the person who did the procedure didn't recognize that the child had eaten. Gave anesthesia, the child aspirated and arrested. 9-year-old pharmacist's son. Yes, IND. No, it was a laceration. Just 9-year-old me, I will just talk to you nicely who treated and suture. And then he aspirated. And they brought the child to Kolebu, but he died. You understand? Now we cover them. And then they came to us now. We cover them completely. And we send only people with what? Membership. Who are, we have 2 consultants who oversee those people with the membership. So even with membership, we are overseeing them. Everybody who has a membership is a specialist. They can do everything, including thoracic cases and some neuro cases. And we still oversee them. So you can see there's a minefield out there. Extremely dangerous. So you would have to do something with your training now. I think you should make the difference in your areas. Otherwise, you can't permeate the other areas. Right. Thank you very much.